Welcome, future clinicians, to the deep dive. Today, we're really jumping into a critical area, infection and disease. Now, this deep dive, it's based on some solid medical sources, and our goal is simple. Give you a clear, sticky understanding, make you well-informed, fast. Think of this as your essential toolkit, understanding how microbes cause trouble, how our bodies fight back, and, well, how you figure it all out. We'll use some mental anchors, acronyms, metaphors, stuff to make it unforgettable.
And it's fascinating, isn't it, how often infection and disease get used, interchangeably. But they're distinct, and that difference is crucial for diagnosis, for treatment. Before we get into definitions, though, a quick question for you listening. Can you have an infection without having a disease? And flip side, can you have disease symptoms without a current active infection? Just mull that over. We'll definitely circle back to it later.
That's a great way to frame it. You've already hinted at the nuance there. So can you lay down those foundational definitions for us from our sources? What exactly separates an infection from, full-blown disease?
Absolutely. Let's break it down. An infection. That's basically when pathogens, these unwelcome guests, get into the body and start multiplying. Think of it like squatters moving into your house. They're there, maybe setting up camp.
Okay, so they've arrived, but maybe haven't started breaking things yet.
Exactly. Disease is when the signs and symptoms show up. That's because of damage to body cells. Now, those guests are breaking things, causing a scene, making their presence known, clinically speaking.
Got it. Infection is presence and multiplication. Disease is the damage and symptoms. That's a really clear distinction. And then there are these other terms floating around. Pathogen, pathogenicity, virulence. Can you quickly define those? Why are those differences important?
Good point. So a pathogen is simply an organism that causes damage to its host. And remember, not all microbes are pathogens, right? Many are helpful or just there. Then you have pathogenicity. That's the ability, the potential of a microbe to cause disease. Can it be disruptive? And virulence. That's the degree of pathogenicity. How harmful is it? How severe a disease can it cause? It's about effectiveness in causing trouble.
Okay, so pathogenicity is can it cause disease? Virulence is how bad can it cause it? Makes sense. Now we have the term straight. Let's meet the players, the uninvited guests. Our sources mention several key categories. What are we looking at?
Yeah, it's a diverse cast. Most commonly, you'll encounter bacteria, single-celled organisms, some good, some bad. Then viruses, tiny invaders. They actually hijack our own cells to replicate.
Right, the classics. What else is out there?
Well, there are also fungi, yeasts, and molds, and helminths, which are parasitic worms, much larger. You've also got protozoa, single-cell parasites, and then a really weird one, prions. These are basically misfolded proteins causing really nasty neurodegenerative diseases. And what's interesting, even within these groups, there's a spectrum. Some are always looking to cause trouble. Others are more opportunistic. They wait for an opening. We'll talk more about that.
Okay, quite a rogues gallery. So how do these invaders actually spread and make us sick? I like thinking of infection as a chain, maybe 6 links. And to stop it, you need to break a link. We're going to use an acronym here, folks. REMPTS. Handy way to remember the steps.
Exactly. REMPTS. Let's walk through it. First, R is for reservoir. That's the pathogen's home base where it lives and multiplies. Could be humans, sick people, or even carriers who don't seem sick. Could be animals. That's where zoonotic infections come from, like rabies from dogs or Lyme from ticks, or the environment itself. Think soil for tetanus, water for Legionella.
Right, the source. Then E.
E is for exit. Portal is exit. How does the pathogen leave the reservoir? Could be vomiting, diarrhea, sexual fluids, coughing, sneezing, skin sores, even across the placenta from mother to baby.
Okay, gets out. Then M, mode of transmission.
Yep. M is mode of transmission, how it travels. Could be direct contact, touching, sexual contact, and animal bite. Or indirect contact. The pathogen hangs out on some inanimate object. We call those objects fomites. Think clothes, bedding, stethoscopes huge in hospitals, doorknobs, your phone screen.
Ugh. Phone screens, always grim.
Tell me about it. And of course, parent-to-child transmission during birth is another mode.
Okay, so REM, next is P.
P is portal of entry. How the pathogen gets into the new host. Maybe inhalation, getting absorbed through mucous membranes, eyes, nose ingestion, a cut in the skin, or even through medical devices.
All right, REMP leaves T and S.
Right. T is the target, or susceptible host. An individual whose defenses are down for some reason. We'll dig into that next. And the S, well, S is for susceptible host too. T is just target, so REMPTS helps you remember the chain. Reservoir, exit, mode, portal, target susceptible host.
That REM-PTS chain is a great visual, but, think about reservoirs and transmission. Is it always clear-cut? Like, in a new outbreak, is figuring out the reservoir or the exact mode sometimes the biggest hurdle? Oh, absolutely. That's a fantastic point. It's often serious detective work. With new diseases, finding the animal source or nailing down how it spreads, that can take years. Think about the early days of HIV, or more recently, SARS-CoV-2. Huge confusion initially about transmission, which made control really, really difficult. That's why understanding this chain is just so fundamental.
Definitely. Okay, thinking about REM-PPS again.
Yeah.
Here's another question for you listening. Which link do you think we target most often in everyday public health to prevent widespread infection? We'll come back to that answer later on. Now let's talk about that last link, the target the susceptible host. I like the analogy of the body as a castle. You've got walls, skin, mucous membranes, guards, normal flora, immune cells, defenses. But sometimes there are weak points, right? It's like the pathogen's always looking for that loose brick. Precisely. Host susceptibility isn't just about the host. It's also about the pathogen's virulence. Key things that weaken those castle walls. A compromised immune system, definitely, like in HIV/AIDS with low CD4 counts or cancer patients on chemo, leading to things like granulocytopenia, dangerously low white cells. Age is a big factor. Infants are vulnerable to certain bugs like group B strep, and the elderly just have weaker defenses overall. Genetic defects can play a role, maybe in the complement system, and breaks in physical barriers, trauma like burns, wounds, or even conditions like cystic fibrosis affecting lung clearance. And don't forget invasive devices. Intubation, catheters. They provide a direct route in.
This is where things get really interesting, talking about opportunistic pathogens. Our sources highlight these. What makes a pathogen opportunistic versus a true pathogen, and why are we seeing more of them?
Great question. Opportunistic pathogens are usually harmless microbes. Often, they're part of our normal flora, just hanging out. They only cause disease if the host is susceptible, if those defenses are down, or if they get into a place they shouldn't be. They're like, squatters who only cause trouble if the landlord, the immune system is away or busy. Staphylococcus aureus, which we'll get to, is a prime example.
Okay, the opportunists.
And the true ones.
Primary or true pathogens. They can cause disease in pretty much any susceptible host. Even if their immune system is generally okay, they're just inherently more aggressive. And why are we seeing more opportunistic infections? Well, it's partly because medicine is getting better. Treatments like chemotherapy, organ transplants, complex surgeries, they save lives, but they can also weaken defenses, creating openings for these opportunists. It's a double-edged sword.
That's a really important perspective. So if the host's defenses are the castle walls, what about the pathogen's tools? You mentioned virulence factors, like a pathogen's Swiss Army knife. What's in that toolkit? Perfect metaphor. These are the specific tools and weapons they used to colonize, evade, invade, get in, get out, all the tricks. So some key examples from the sources. Adherence factors, like grappling hooks, things like polio, that let them stick tightly to our cells.
Sticking is step one. What about hiding or doing damage?
Right. They might have capsules. Think of these as invisible cloaks that shield them from being eaten by immune cells. Phagocytosis. Invasion factors help them spread into tissues. And then toxins, actual poisons that damage host cells. Two main types. Endotoxins, part of the bacterial cell wall, released when the bacteria die. And exotoxins, potent proteins actively secreted by the bacteria.
Wow, that's quite an arsenal.
Yeah.
But looking at these tools, can a pathogen be too virulent? Like, if it's so effective it kills the host really quickly, doesn't that hurt its own chances of spreading?
That's a really sharp question. And yes, it's a classic concept in pathogen evolution. Extremely high virulence can sometimes be counterproductive for the pathogen. If it kills a host too fast, it might not have enough time to transmit to a new host. It limits its own spread. So many successful pathogens strike a balance, cause enough illness to allow transmission, but not so much that they eliminate their ride, so to speak.
Fascinating balance. Okay, shifting gears. As future doctors, how do you put all this knowledge together when a patient actually walks in? It's a complex process, right? We need a systematic approach. Let's use another acronym, HESII, for the diagnostic steps.
HESII. Think of it as your roadmap. H is for history. This is your detective work. Get a thorough patient history, the main complaint, past medical stuff, meds, family, social, review of systems, the whole picture. E is for exposures. Any contact with infectious agents, recent travel, sick contacts, crowded places, sexual partners, hospital stays.
Got it. History, exposures,
Yeah.
then S.
S is symptoms, what the patient tells you. How bad is it? How long has it been going on? Is it systemic all over or focal in one place? Many minor infections are diagnosed just based on this clinically.
Okay. HES, Then I.
First I is investigations, lab tests to confirm things. This could be cultures, blood, swabs, throat, blood tests like liver function tests, LFTs, full blood count, FBC, C-reactive protein, CRP, maybe screening tests like for HIV, or imaging X-rays, CT, ultrasound.
All right, investigations. And the final I.
The final I is interpretation, which really combines with your examination, your physical assessment, looking, tapping, listening, observation, percussion, auscultation. You interpret all these findings together, the history, the symptoms, the test, the exam, to piece together the puzzle.
HESII. History, exposures, symptoms, investigations, interpretation, examination. Another great anchor. Okay, let's make this real. Let's apply these concepts to some common culprits you will see. We'll focus on 3: Staphylococcus aureus, Streptococcus pyogenes, and Candida albicans. Let's look at their specific strategies. First, Staphylococcus aureus, often called Staph aureus. Gram-positive Kochi. Notorious opportunist. Remember, often lives harmlessly on us, but give it a chance. Bam. So what makes S. aureus so formidable?
It really is its virulence factors. They give it a massive advantage. It uses adherence factors, these adhesins like molecular Velcro sticking firmly to surfaces. It pumps out exotoxins and enzymes that damage cells, create pores, help it spread deep into tissues. And a key one, coagulase. This enzyme forms a fibrin clot around the bacteria. It's like building a little protective wall, hiding it from immune cells. This isn't just clever, it really highlights the challenge for treatments. We're not just fighting growth, but also these sophisticated evasion tactics.
Right, that hiding ability is key. And its versatility means it causes a huge range of diseases. We know about skin and soft tissue infections, SSTIs, super common. Anything from minor folliculitis or impetigo up to severe cellulitis or even flesh-eating necrotizing fasciitis. But its toxins cause specific syndromes too, like staphylococcal scalded skin syndrome, SSS, mostly in young kids, under 5. You see widespread redness, big blisters, that positive Nikolsky sign where skin peels easily. It can lead to serious fluid loss.
Absolutely. And moving systemically, S. aureus causes staphylococcal toxic shock syndrome, TSS. Here, the toxins act as superantigens, causing a massive immune overreaction cytokine storm. Leads to rapid high fever, rash, low blood pressure, multi-organ failure. Risk factors. We used to hear about tampons, but also post-surgery, burns, diabetes, alcoholism.
And it doesn't stop there, right? Bone infections, heart.
Exactly. Osteomyelitis, bone infection, often after trauma. And infective endocarditis, infection of the heart lining. S. aureus is so virulent it can infect even normal heart valves, which is quite scary. It usually needs some underlying issue plus bacteria in the blood, bacteremia.
So how do we manage this tricky bug?
Well, specific antibiotics are key. For something severe like TSS, often a combination like clindamycin plus oxacillin. If you suspect MRSA, methicillin-resistant S. aureus, or the patient is penicillin allergic, you'd reach for vancomycin. It really highlights the antibiotic resistance challenge. And often, surgery debridement, cleaning out infected tissue is critical, plus supportive care like fluids.
Okay, that's S. aureus. What about its cousins, the coagulus-negative staph con, like Staphylococcus epidermidis?
Right, S. epidermidis. Key difference. It's coagulus negative. It's a super common bug on our skin, usually harmless.
But clinically relevant sometimes.
Definitely. While often just a contaminant in lab cultures, it can cause serious infections.
Yeah.
Especially in immunocompromised patients or those with medical devices. Its main trick, biofilm formation. It creates these slimy layers that let it stick really well to things like catheters, prosthetic joints, heart valves. That's how it causes infections like catheter infections or prosthetic valve endocarditis.
Right.
So finding it doesn't automatically mean infection, but you have high suspicion if the host is vulnerable or there's a device involved.
Got it. Okay, next major player, Streptococcus pyogenes, also called Group A Streptococcus or GAS, the chain reactor. Another gram-positive Kashi, but these guys form chains, not clusters like staph, and they're catalase negative, identified by that Lancefield Group A antigen. What's in the S. pyogenes arsenal?
It's got its own set of potent virulence factors, streptolysins and hemolysis. These literally destroy cells, especially red blood cells, superantigens. Just like S. aureus, these can cause massive immune activation, leading to shock. Hyaluronidase breaks down connective tissue, helping it spread. Spreading factor. Streptokinases. These are clot busters. They dissolve blood clots, which might otherwise wall off the infection, so it helps the bacteria spread further. And crucially, M protein. This is a major surface protein that acts like an anti-phagocytosis shield. It prevents immune cells from grabbing and eating the bacteria.
Another impressive toolkit. And it causes a lot of familiar diseases, obviously pharyngitis, strep throat, also skin infections like impetigo and cellulitis, similar to staph, and scarlet fever, right? That's caused by the exotoxins, the superantigens. Mostly kids 5-15, you see the sore throat, fever, rash, swollen nose, that classic strawberry tongue. And treatment with penicillin is vital to prevent complications like rheumatic fever.
Exactly. Rheumatic fever is that post-infectious autoimmune reaction. And yes, pyogenes can also cause toxic shock syndrome, just like S. aureus. Severe multi-organ stuff can also cause endocarditis.
So management for severe strep infections.
Often combination therapy, again, like benzylpenicillin plus clindamycin. Clindamycin helps reduce toxin production. Vancomycin, again, for penicillin allergies. And for severe cases like toxic shock or necrotizing fasciitis, ICU support, fluids, often aggressive surgical debridement are absolutely necessary.
Okay, we've covered two major bacteria. Let's switch gears completely now. Fungi. Let's talk about Candida albicans, the fungal opportunist. Very common, especially for opportunistic infections. What's Candida's game plan?
Candida albicans has some unique strategies. A really key one is polymorphism. It can switch its shape between a single-celled yeast form and a filamentous invasive hyphal form. This shape-shifting lets it adapt, go from being a harmless commensal to an invasive pathogen.
So it can disguise itself or change form to attack. Clever. What else?
Like the bacteria, it can form biofilms, helps it stick to surfaces, including medical devices, and protects it. And it secretes hydrolytic enzymes, things like proteases, SAPs, phospholipidases, emulsins. These enzymes damage host cells and help it break through barriers and invade tissues.
A master of disguise and invasion. What kind of diseases does this lead to?
Most commonly, oral candidiasis, or thrush. That's overgrowth in the mouth. Presents as those white patches or plaques, maybe taste changes, sore red spots, burning. Risk factors: poor oral hygiene, smoking, using steroid inhalers, recent antibiotics, things that disrupt the normal mouth environment. Also causes vaginal candidiasis, yeast infections, very common.
And in more vulnerable patients.
Yes. In severely immunocompromised hosts, think advanced HIV, patients on chemo, radiation therapy, Candida can cause serious trouble. It can disseminate, spread through the bloodstream. You can get esophageal candidiasis, pneumonia, meningitis, even endocarditis caused by Candida. Much harder to treat then.
So how do we manage Candida?
For localized stuff like mild thrush or vaginal candidiasis, topical antifungals usually work well, clotrimazole and nystatin. But for severe disease, or if it's disseminated, especially in immunocompromised patients, you need systemic antifungals. Fluconazole is a common one, sometimes others like amphotericin B for really serious cases, and treatment might need to be quite long.
Wow. Okay, that's a fantastic overview of those three key players. We've covered a huge amount today. Just to recap for everyone listening, remember REM-PTS for the train of infection, reservoir, exit, mode, portal, target susceptible host, and HESII for the diagnostic approach, history, exposures, symptoms, investigations, interpretation, examination. We saw how each pathogen's unique Swiss Army knife of virulence factors dictates what it can do.
And let's revisit those questions from the start. Can you have an infection without having a disease? Yes, definitely. Think of asymptomatic carriers or subclinical infections where the bug is there, multiplying, but no symptoms yet. And can you have disease symptoms without a current active infection? Yes, again. Think autoimmune conditions triggered by a past infection, genetic disorders, or even lingering effects from toxins after the bug is gone, like post-streptococcal problems.
Right. And that other question, which REM-PTS link do we target most in public health?
That would be M, the mode of transmission. Think about it. Hand washing, masks, condoms, cleaning surfaces, controlling mosquitoes. They're all about interrupting how the pathogen travels. It's often the most practical target for broad prevention.
Makes perfect sense. So the big takeaways for you listening. Infection is the bug multiplying. Disease is the signs and symptoms. Pathogenicity, potential to cause disease. Virulence, degree of harm. Pathogens use diverse virulence factors to stick, hide, invade, and damage. Host susceptibility is key. Opportunists exploit weaknesses. And we saw S. aureus, S. pyogenes, C. albicans, common bugs with unique tricks and disease patterns.
You know, understanding this intricate dance host versus pathogen, the pathogen strategies, the host defenses, it really is fundamental for your medical journey. As you go on, you'll see how breaking down these complex things into models like chains or toolkits really helps you think clearly, diagnose, and treat effectively.
Absolutely. And here's a final thought to leave you with. In this era of growing antibiotic resistance, how might a deeper understanding of specific virulence factors not just killing the bug, but maybe disarming it? How might that revolutionize future treatments for infections like the ones we talked about today? Something to ponder. Keep digging, keep questioning. Thanks for joining us on this deep dive into infection and disease. You've definitely taken a shortcut to being well informed.